On behalf of the authors, I would like to thank the ACP for the special opportunity to present our unique case report. We have no conflicts of interest to disclose. We present a case of Streptococcus anginosus pericarditis with tamponade in the setting of disseminated coccidiomycosis. Disseminated coccidiomycosis is caused by the dimorphic fungus Coccidioides immitis spreading from the lungs into other organs. Streptococcus anginosus is a gram-positive facultative anaerobe of the Milleri group typically found in the oropharynx. We present a case of strep anginosus pericarditis in a 37-year-old man with disseminated coccidiomycosis complicated by pericardial effusions. A 37-year-old man with disseminated coccidiomycosis, refractory to outpatient fluconazole therapy, was admitted for chest pain, cough, and shortness of breath. On admission, CT imaging revealed persistent cavitary opacities, seen in Figure 1 below, and a new large subcarinal lymph node. A bronchoscopy with biopsy of the subcarinal node was obtained on the 7th hospital day to rule out alternative diagnoses. Despite treatment with amphotericin, his symptoms progressed and an echocardiogram revealed an enlarging pericardial effusion. There were clinical and echocardiographic signs of tamponade, as seen in Figure 2, and a pericardial drain was urgently placed on the 17th day of admission. Cultures from pericardial fluid grew Streptococcus anginosus. With approximately 300 milliliters of serosanguinous fluid draining per day, despite antibiotics and antifungals, repeat echocardiograms showed persistent adhesions and loculations within the pericardial space. Intrapericardial TPA infusions were trialed for 5 days to lyse adhesions, yet high volume output continued. The patient progressed to develop a large right-sided loculation with right atrial compression. On the 35th day, the patient underwent a subxiphoid pericardial window with drainage of this loculation and placement of a large fluted drain. Inferior and left-sided adhesions were quite dense and could not be mobilized from this approach. Despite having a large bore drain along the right heart, he developed recurrent tamponade 2 days later from reaccumulation of a large complex left-sided and posterior fluid collection, and he progressed into cardiopulmonary arrest. The patient responded to 3 cycles of CPR and was taken for emergent sternotomy with full lysis of adhesions and evacuation of hematoma. The pericardium was thickened and inflamed, with fibrinous exudate and inflammation of the epicardial surfaces, as seen in Figure 3. The patient was treated with a short course of steroids in addition to IV amphotericin and ceftriaxone. He remained stable with primarily serous drain output. He was subsequently extubated and pericardial drains were removed 1 week later. 2 infected maxillary molars were extracted 5 days later, and he completed a course of antibiotics. The patient demonstrated gradual clinical improvement over the following 2 weeks, and after 56 days in the hospital, he was discharged home on long-term isobuconazonium and colchicine. Serial echocardiograms have demonstrated normal biventricular function and no recurrence of effusion. Disseminated coccidiomycosis is a relatively rare and severe form of Coccidioides immitis infection, which commonly affects the skin, skeleton, or meninges. Pericardial involvement is rare, with the published literature primarily consisting of case reports. In our case, the pericardial effusion was solely presumed to be due to coccidiomycosis, and the finding of strep anginosus in the pericardial fluid was highly unexpected. Strep anginosus may have infected the pericardial space via aspiration in the setting of infected molars or translocation from a necrotic lymph node during the bronchoscopic biopsy. Management of bacterial pericarditis with antibiotics and drainage may be complicated by adhesions and loculations, leading to focal tamponade and hemodynamic instability. A multidisciplinary approach with cardiology, infectious disease, and cardiothoracic surgery should be considered. We thank you for your time.